Welcome to another episode of the podcast. Today we are talking all about airway health and tongue ties. I have Mel Van Schelven with me, who is a registered dental practitioner, an oral health therapist, and an orofacial myofunctional therapist. Now that, if you have a tongue tie, I don't know if you can say that, but she's also the founder of the Face Place. So welcome, Mel. But before we get into this massive topic, can you tell us one thing that you've done today to take care of yourself?
Hi. Thank you for having me, Hillary. Yeah, that's a great question. I have been working on just small steps of self-care. I'm a mother, as I'm sure many people listening, maybe most people listening are. Um, and I've been trying to simplify how I take care of myself a little bit. So the first step in that just recently has been having a full glass of water for the start of my day. So I could definitely tick that box today.
Yeah, self-care doesn't have to be complex, does it?
No, I think yeah, and I think we make it hard. I feel like I've been making it hard for myself. So dropping it back, just make sure you start your day hydrated. That's a really good first step.
Yeah, it definitely is. So can you tell us a little bit about yourself and what it is that you do?
Yeah, so work-wise, lots of words in my titles. I always feel like I'm apologizing for them. They sound a lot more complex than they really are. Of course, as you can hear in my accent, I am Australian. Um, Oral health therapist is I believe is only Australia and maybe New Zealand have that title, so it does throw people a little bit. It's very similar to a dental hygienist, so I've spent a lot of time working with gum disease and doing preventative care, but it's also merged with another profession here in Australia called dental therapist, who primarily works with children. So it's a dual qualification of those two things. So I've started out in clinical dental practices. I've worked in public and private practices since 2011, and Orofacial Myofunctional Therapist um, is based on the muscle function of the mouth and face. So oro is mouth, facial is face, myo is muscle. It sounds very complex, but it's really not. We're just looking at how all those structures work in the mouth and face and whether they're supporting health or not.
And how did you get into this area? It seems like, at least in my little bubble, I'm hearing lots about airway health over the last few years, but it wasn't maybe that big of a thing, or it wasn't trendy a few years ago when you would have gotten into this. Like, what brought you to this?
Yeah, well, I started with the dental qualification, but my approach with health is I guess, it's a bit of an overused word, holistic. I don't like to just kind of take things at face value. I like to know why. Always got more questions. And when you do standard dental training, so again, for the listeners who aren't not as familiar with Australia, I've been to university, I have a degree. When you do that kind of training, you don't get a lot of a holistic view. You have a bit of a limited idea of what's causing things with health. Bigger picture things aren't always included in that. And airway health and oral and facial muscle function definitely was not in my degree. So it was more about me wanting to know why we have kids with big tonsils, why so many people have crowded teeth. Like it's just a standard thing that by the time you're a teenager or early 20s, you're getting your wisdom teeth taken out. Why is everyone lining up at the orthodontist? Like to me, that's just not acceptable. It's not okay that that's just what we're doing. So that led me down that path of looking at things like what we're eating, how we're breathing, and how we're sleeping. And that's basically the basis of orofacial myology, which is the study of the muscle function in the mouth and face. And I did that course a couple of years after I graduated from uni, the introductory course, which is a 4-day course for health professionals. And that is kind of what opened all the doors. I don't know how anyone could ever walk out of that training and not have a completely different mindset around what they're doing with any facet of health, really, but definitely in dental. And yeah, from there it's just unending learning. It goes on and on and on. There's you never know enough about this topic.
Is it something that is starting to be more talked about and taught in dental education? Or is it that still always after the fact, even now?
I think it's creeping in a little bit. There's definitely more awareness from a dental sleep medicine point of view of using appliances and things for sleep apnea, that kind of process. But from what I know of, so I graduated nearly 9 years ago now. I've had a couple of people that I know have gone back and done other dental related study. It's not currently being taught to this extent. There is still very much I guess, a mindset that you have braces and that's it. There's not really much more to it. Um, but yeah, as you said, sort of from the start, we live in our own little spheres, our own little echo chambers. To me, it seems like it's gathering a lot of attention and it's talked about a lot. But once I step outside my little area of people that I know and talk to regularly, you do realize that it still has a very long way to go in a more mainstream context.
Yeah. And why is airway health so important? Like it seems to me that it affects everything that we do and all aspects of our health. Can you tell us
Yeah, it
more
really
about it?
does. Yeah. Well, breathing being essential to life. Yeah, very important that we breathe, of course. But the way that we breathe is equally as important as the breathing itself. We have a lot of processes that are supported by us breathing properly, like our nervous system regulation, our posture, the way that we use the muscles in our mouth and face rely on the way that we breathe. We're breathing through our nose. It means we've got to set everything up there to make that happen. And then we have flow on effects to almost every other area of health. I'm not familiar with something that doesn't relate to how we're breathing. So, sleep, immune system function, our digestion, our behavior, and our moods. It's how we eat and what we eat can all be influenced by our breathing, whether directly or indirectly through those other processes it impacts. So, yeah, it's very important that we breathe properly through our nose most of the time, and that is calm and regulated so that the rest of our body can function as it needs to.
And what do you mean by calm and regulated? If we breathe through our nose, are we more likely to breathe in a calm way, or we also have to train ourselves to breathe slower, like or in our bellies? Like, what does that calm breathing look like?
Yeah, so broadly speaking, a lot of humans, we are over breathing. We're breathing too fast and too shallow. And yes, you can still do that through your nose, but it's more likely to be happening when you do that through your mouth. So, nasal breathing, when it's all happening properly, requires you to be really expanding your rib cage and your lungs, not blowing your stomach up with air or lifting your shoulders up. So, that's going to support good posture. You need good posture to have that to happen. Um, I've completely lost my train of thought already. Sorry. I was just like, I could keep going with this, but I'm going to be confused. Could you ask the question again?
Yeah, how do we breathe in a more calm way that helps regulate our nervous system? Is it just breathing through our nose, or do we have to focus on other things in our breathing as well?
Yeah, so breathing in a more calm way means not breathing too fast or too shallow, which we're often doing. Many people are breathing too often, which seems a little bit counterintuitive. I think we need oxygen. We should be breathing a lot, but we actually need to slow down. We need to have more tolerance in our body for carbon dioxide so that we're not rapidly trying to bring in oxygen more often. It generally means breathing through your nose, yes, most of the time, because you're going to get more air pressure and more air straight into your lungs to do that, to expand them. And man, I should have had another coffee, I think. Goodness me. Um, Slow regulated breathing. So it is through the nose and it I cannot speak. My goodness. This might not be my topic today.
That's all right. It's
Maybe you can chop enough of that to make it make sense. My
yeah,
goodness.
for sure. And yeah, it's 7:45 my time at night, so
Oh,
I totally feel you. I'm on the opposite end. You're waking up, I'm going to
oh,
sleep, so neither
mm,
of us are
that's really bad.
very fresh. No. Oh my God, what you're saying is great though. Yeah.
Hmm.
Yeah. So can we talk about tongue ties? Can you tell
Hmm.
us a little bit about like tongue ties? What exactly are they? What are we looking for in our kids to know if they have tongue ties?
So I have my own kind of put together definition of what tongue ties are because unfortunately there is no universal definition. Depending on what research, what literature you read, you may come across some definitions, but none of them are universally accepted. So every time you read something different, you may read a slightly different explanation. So what I have put together for myself, which I think makes most sense and covers everything that you need to think about when we're talking about tongue ties is it's the restricted mobility of lingual frenum, which is the tissue under the tongue, which contributes to limited or altered function of the mouth and face and a person's general health and well-being. And that's the real kicker at the end there. It can't just be about what's happening in their mouth and face. It's about general health and well-being as well.
So that's more like how it's affecting their behavior or their sleep or mood or things like that.
Yes, yeah. So looking at those flow-on effects, not just getting tunnel vision and looking at mouths only, even though the problem is originating in the mouth, it has so many relationships and connections. We need to be looking at the whole picture of a person, which helps us diagnose and also helps us treat.
And are there some people that have tongue ties that if you only looked at the mouth, it would be evident that they have a tongue tie, but it doesn't actually affect anything else or not so much?
They always have flow-on effects. As to the severity of that is probably a better way of looking at what you mean is like some people will be really significantly infected in other ways, and other people, yeah, will live a life that seems less affected, or maybe they have minor ailments that they didn't realize had anything to do with their tongue.
Yeah, okay. And how common are tongue ties?
Ooh, that's a very tricky question. Like most things are with tongue ties, unfortunately. Um, So I the most recent research that I've got that can we can quote a number was a systematic review from 2021, and that said 8% is the prevalence of tongue ties, reported in infants. But we have a lot of problems with that kind of data because we don't have universal definitions, we don't have universal diagnostic criteria. It's very hard to get black and white evidence because we're not comparing apples with apples a lot of the time. And that systematic review did also predict that with improved like data sets with those sorts of things, as we can gain more universal ways to diagnose and define ties, that review did predict that maybe as much as 18% in future literature. Um, so it is a hard thing to pinpoint because it's not like there's some sort of countrywide or global database of every infant that's born is assessed in the same way and reported on. But that's something to go on, that it is at least around 8%, so 8 in every 100 babies born.
Yeah, with my two kids, I had them both in Australia, and nobody even checked for that, even when midwives came to the house to help me with breastfeeding. And they talked all about position and how I sat and the position of the baby's mouths, but nobody looked in their mouth ever.
Mm.
So
And
I
isn't that
think that,
just
yeah, like that number
so
must
like,
be so much bigger than 8%.
yeah, I assume it is bigger than 8%, but I also acknowledge my own bias that I see people with ties and oral dysfunction. So I'm seeing a biased population myself. But from few years ago, I haven't worked in a dental practice since I went on maternity leave with my daughter, but I was finding ties in anyone and everyone, older people, younger people. So even just the collection of how we have started to kind of collect this data, it's not possible to do that retroactively. We can't do it to the past, so we don't really know what's out there in older populations and things now. But yeah, bit of a hard one to answer very clearly.
Yeah. And what causes tongue ties? Or what do we know so far about what causes them?
Yeah, so I guess we can talk about like the process of how they form. So if a baby has a tongue tie or not, that's going to happen in first trimester of pregnancy. So by the 12th week in utero, the tongue should become a separate process from the floor of the mouth and the jaw. So they're initially sort of all together, and then they go through a process of cell death that separates the tongue. If that doesn't happen as it should, then you're left with that like more residual tissue. So the frenum itself, the tissue that attaches the tongue to the floor of the mouth, that's fine. That's a normal thing to have. So looking under any baby's tongue, you're going to see one, or at least we have research that indicates maybe like 99% of people have them. They're pretty common or pretty standard. Um, so that frenum should remain, and that is fine. But if that process didn't go well, then that frenum can be attached in the wrong place. It can be too thick, too tight, and restrict the movement of the tongue in the pregnancy. Now, why that happens, again, is one of those bigger questions that we don't have black and white answers to. We do know that because it's happening so early in a pregnancy, we've got pretty strongly coded things going on there at that point. Like that's pretty heavily like genetically influenced for that to be happening within the first trimester of a pregnancy. So there are genetic factors, and you're going to see that across families. When we have one child with a tie, we have other children and parents and cousins and aunts and uncles, and before you know, you're talking about granddad that doesn't chew food properly and doesn't speak well. It's pretty strongly within families, but as I'm sure is probably within what you talk about and other guests you've had, we do have this concept of epigenetics, where we have external influences on how we're expressing our genes. And that's the question we don't really have answered yet. Why are we expressing this way? Why is this happening? What's causing that process to go wrong or go differently is an answer we don't have yet, other than the more broader strokes that we know about human health, where our diet, lifestyle, and environment is not really supporting us very well at the moment.
Yeah, so this is one of those things that epigenetically, maybe our modern lifestyle is contributing to them being more severe or more common.
Yeah, and people have theories. Again, they're just theories. But that in the past, when we didn't have processes like bottle feeding and formula, that unfortunately infants born with significant restrictions in their mouth wouldn't have been able to feed and wouldn't have been able to live. But as we've had our modern abilities to support these babies, whatever genetic factor is happening there is like proliferating more. It's continuing down family lines because we've been able to live with it. It's a theory.
And why do we need to care about tongue ties? Like, what is the impact of a tongue tie on our children's health, their development, all of that?
So starting with our baby, they need their tongue to move freely and properly in order to breastfeed effectively. And just like you sort of mentioned before, where how broad is this spectrum of how it affects a person? You can definitely have a baby who has a tongue tie who appears to feed well. So from the untrained eye or from mum's perspective, that they do drink enough milk and they do gain weight. But you can also have the baby that is at the point of like failure to thrive because they just cannot get enough milk. They're not gaining weight. They're never settled. They don't sleep well. So there's really quite a big spectrum of the impact on babies from that point of view, but they will also affect a bottle fed baby as well because bottle feeding is more technique sensitive than we tend to think of it. And following on from there, being able to breastfeed and use your mouth correctly is very important for the growth and development of the mouth and face, for breathing and for sleep. So if it doesn't happen right from the start, then there are flow-on effects to how babies may take to solids, how they develop their mature swallowing patterns, their speech, and um, posture. Sorry, it's like, what have I already said? Posture, nervous system regulation, just exactly like when we were talking about airway, because tongue tie can have an airway relationship as well. Once you start kind of altering or having negative impacts on one area of health, it's like a domino effect. You are going to keep accumulating other other problems, but those main ones to look at initially is breastfeeding, eating, speech, and sleep and breathing.
Those are all really big areas, aren't they?
Yeah, yeah, they're huge.
Yeah.
It is really huge, yes.
And how can it affect their eating? I work with mothers to support them to help their kids not like be fussy eaters and be able to eat properly and eat all the foods that are served and things like that. So this obviously does have a big impact on that. So could you speak to how that might contribute to picky eating?
Yeah. Yeah, it can contribute to picky eating in that the tongue is used for directing food in our mouth. So not just for swallowing it, gathering it up and swallowing it once we've got something that's like mushy and smooth for us. It also directs food from side to side. It cleans up the mouth afterwards. So from that first point of view, if it's very difficult to navigate food in your mouth, then you are going to find textures that you prefer. And in most cases, in our picky eaters, that's white starchy carbs that are very easy to navigate, very easy to swallow. Um, and also, if things are stuck in the mouth, if it's hard for your tongue to go around and clean up after them, then you're not going to want things that are more fibrous and difficult to clean up after as well, because the tongue is kind of our first oral hygiene mechanism. It goes and cleans up everything after we've been eating. Um, and then we also have the element of if our tongue isn't moving properly and we're not very good at using it, there's altered, like, sort of sensory perceptions going on there as well. So, what I've seen in a lot of the kids that I work with is when you're doing their assessment and saying, can you touch your tooth with your tongue? Can you lift it up? Can you do this? Can you do that? Don't even know what I'm asking them to, even asking them to do. Like, they're at an appropriate age where they should be able to move their tongue and do these movements like I'm asking, and they don't even know what I mean because they've not been able to go through all those important milestones of using their tongue and learning like their sort of their oral proprioception and things like that. They don't even really know what's happening. So then if you want to go and put a piece of steak in there, that's going to be hard work. If we have a child who is having difficulty with their mouth from a sensory as well as sort of a motor muscle movement perspective, spending a few minutes chewing a piece of steak and then gathering it all up to swallow, there's a lot of things going on there that can be really hard for kids to take on. And then you've got your kind of the next step out, those bigger, broader impacts where we can talk about whether if we haven't had the best development of the mouth and face, and then we've got airway issues because of that. When you mouth breathe, you can have altered taste perception as well as the altered sensory issues within the mouth as well. And then if sleep and breathing are impacted and we've got a nervous system issue going on, then we've got like a very stressed child. And that's not a very it's not really the circumstance you want to come to a meal to start trying a new food or a difficult food when you haven't slept well, when you don't like the taste of it. It's hard to chew, it's hard to swallow. You're breathing through your mouth and you can't do that when you're chewing a lot of food. So there's a lot of things that kind of pile in on each other there, and they're not always just about the tongue, but the tongue can be often at the base of that as to what started a lot of those domino effect kind of issues.
Is is the tongue a big factor in our mouth breathing? Like it seems like from an untrained eye, to me, they're correlated. Is that true?
Yeah, definitely. Not always necessarily as the root cause, but what happens when we have a tongue tie is that the palate is shaped differently because the tongue is supposed to be up on the roof of the mouth, placing pressure there, helping those bones spread and grow a nice wide U-shaped palate. So that's going to house all the teeth that you grow with that grow in your jaw without overlapping them and crowding them. And it's also the base of your like of your nose, your upper airway structures. So when we have tongue ties, we have high palates. So we have smaller space for teeth, we have a smaller space for that airway. So again, not a black and white thing. I don't want that to be misconstrued, but you're at a higher risk or a higher rate of people who do have nasal breathing problems. And it's very circular. Most things in this area kind of feed into each other and they can be very chicken and egg. But in order to mouth breathe, you need to keep your tongue down to get air into your mouth. If you have your tongue suctioned to the roof of your mouth where it should be whenever you're not eating or speaking, then you can't mouth breathe. So you've altered the function of your tongue and then kept that cycle of the suboptimal growth of your palate going because the tongue's not resting up there to place the pressure on it. So, yes, the tongue has a big role in airway health. And then from a sleep perspective, if you don't have good control of your tongue and the ability to hold it on the roof of your mouth, then at nighttime, that process of tongue posture supports the soft tissues in your airway and helps them like remain patent. When your tongue drops down, then those structures aren't supported anymore, and your tongue can even drop back and fall into the airway and be part of an obstructive process, like with sleep apnea. So, yeah, it has a very big relationship with how we breathe.
So what do we do about it if we
Yeah.
do realize that our babies have tongue ties or our kids or even ourselves as adults?
Mm,
Where do we even start?
yeah. Babies, so our newborns, our little ones, they need a lactation consultant, an international board certified lactation consultant, and preferably someone who has this orofacial myology training. Because as you said, you had people visiting and looking at breastfeeding, and no one's even looking in the mouth, which is so bizarre considering it's the mouth that's doing all the work and no one's looking in there. Secondary from looking in there, they need to know what they're looking for and the variations of normal. The amount of times I've heard parents have been telling me, someone just recently told me this again, that they've been told their baby had a high palate, but it was normal. And I'm just going, yeah, because the pediatricians are just seeing across the board, they're seeing so many high pellets that what you see every day, you're going to start to think it's normal, right? So for babies, that IBCLC is that first point of call, because what we want primarily from babies is we want them feeding. Like that's the main thing that we're focusing on with them. So we need someone who understands the feeding. So I don't work directly with babies because I'm not an IBCLC. And someone who's trained in orofacial myology, that IBCLC, that's the right person for this. They'll have a team, like they'll know the people in your area that are right for this, that they regularly work with and they get good outcomes with. That's typically going to involve someone who does body work. So that's a chiropractor or an osteopath here in Australia. But I think in North America, you also have physical therapists and occupational therapists that may do some of that sort of work. But in Australia, it's mostly osteo and chiro. And once you've gone through this process of diagnosing whether there's a tie there or not, supporting baby to their best of their ability now to recover from their birth and to optimize their feeding, if a tie is definitely present, then you need someone who does surgery in order to, there's a lot of terms for it, but I like to say release that tissue under the tongue that has not formed properly and is affecting their tongue's movement. And that again will vary in different countries as to who you see for that. In Australia, that is most commonly a dentist. We also have ears and throat specialists and pediatricians that might do that work as well. But I think that's probably pretty similar across most countries. Sometimes nurses or nurse practitioners can do that surgery as well, but that's not as common. So ultimately, there is a surgical treatment, I guess. So what are we going to do about it? Surgery is, in most cases, is the answer to that, but it's not the only part of what needs to be done. There needs to be, I guess you call it like prehab and rehab for the surgery. We don't kind of just go in cutting underneath tongues and just expecting everything will correct itself magically just because baby has now technically has the ability to move their tongue. But that's babies. Older children, we don't need the IBCLC anymore, but they have a very similar process where they need someone who is expert in what they need to do right now, someone to do the body work and someone to do the surgery. I guess there are different opinions within this industry about surgery, when to do it and how to do it. Like that's quite a big topic. My opinion is that when we have a properly assessed and diagnosed tie, you always need surgery. But as to when you do the surgery is kind of that more individual question where we look at what's happening for that person right now. Are there big impacts for them right now? Do they have access? Do they have the finances? Like there's a lot of things to think about other than just let's line you up and cut something underneath your tongue just for the fun of it. It is quite a complex topic.
And I assume it's better if you do it earlier because then it helps all those things progress, like your development and your health to progress optimally. But is it ever too late? Like as an adult, should people be getting
Never
this
too
done?
late.
No.
No, I've seen case reports of people in their 80s. So,
Wow.
yeah, not too late. But you're right. Preferably earlier because once you can restore the function that a baby needs with their feeding, then you're setting them up to have the correct function for how they're going to eat and how they're going to speak.
So can you talk to us a little bit about this prehab and this rehab? Is that the myofunctional work that we would be doing?
Yes, yes, orofacial myofunctional therapy. So that looks a little bit different in babies and even in toddlers because um, the way that that therapy works is you're demonstrating movements and you're getting them to repeat them. And it's a little bit like physiotherapy or physical therapy, where you do repetitive muscle movements over a period of time at home and then you come back in and get them updated or made more advanced. So babies and toddlers can't mimic us like that. So in babies, what IBCLCs and bodywork providers will do is they're going to work with baby's natural function. So they're going to be optimizing feeding. They're going to be working with their reflexes and nerve function to stimulate them to move their tongue side to side and up. Um, and then in toddlers, it's a bit harder to make surgical decisions about toddlers because they're not going to participate in those therapies in the same way. And they will need a general anesthetic to have a surgery done. It's not, not appropriate and not done to hold a toddler down and cut their mouth while they're awake. Like that's not done. So we've got more cost, more risk from a general anesthetic, and toddlers not really being able to participate in the therapy in the same way, then the surgery outcomes might be a bit altered because they're not going to repair their muscle function in the same way. It's not that it's never done; it's just a bit harder to make those decisions. But from age 4 to 5 is when they can actually participate in orofacial myofunctional therapy. So, depending on what kind of point of function they're at before they have a surgery, that may be a couple of weeks or a couple of months of therapy to get them to the point where they are ready to have surgery. They need to sort of achieve a certain point of muscle function in their tongue to be a candidate for that. And every surgery provider is going to have a slightly different preference for what they want people to be capable of before they have a surgery. But a lot of the time they do defer to the therapist that does that to say whether they're ready or not. And then after they have their surgery, they do very similar things that they did before the surgery, but now they've got freedom of movement of their tongue and they'll do them a lot better. And same thing again, it really depends on what kind of dysfunction they've been living with, what kind of problems they've had as a result from this, as to whether that's a couple of weeks or a couple of months of surgery, of therapy after surgery to rehabilitate, to get that tongue moving independently, living up on the roof of the mouth, closing their mouth and nasal breathing again.
And if we say somebody got a tongue tie release and they didn't do that therapy, would they just not know how to use their tongue properly? Or is it that it would grow back? Like what would happen there if you didn't do the therapy? It just wouldn't be as optimal as of a result.
Yeah, it's very unlikely to be an optimal result for you. Um, it feels like all these questions get answered the same way, but it really does depend. Like what kind of problem we having prior to. Um, so people with say like head and neck pain, adults, it's one of the biggest signs in adults that they may have had an undiagnosed tongue tie. They've got chronic head, neck, and jaw pain. And most adults that I know and case reports that I've seen in those circumstances will have immediate or very fast relief of that pain. And you can get that's the surgical intervention in that case. So you could have that without having done your therapy before or after. But as to whether you maybe have a return of that because your muscle function continues to be dysfunctional and continues to cause you pain patterns, um, is kind of an open-ended, unknown question. But for the most part, you're not going to just automatically rest your tongue in the right place and move it the right way independently just because you've had surgery. So I guess more of those maybe top of the pile relief is more likely, but longer term or the bigger things like how you're breathing and sleeping or able to speak, it may not be quite the same.
Yeah, that makes sense. So I guess I skipped ahead and started talking about treatment, but
Yeah, that's fine.
I want to know about assessment. How do we know
Yeah.
if 8% or 18% or whatever percent of people actually have tongue ties? How do we know if our child has one? Like you're talking about
Mhm.
breastfeeding being a struggle and even it can affect bottle feeding. Like that could be obviously a sign. But what are some other signs that I guess signs and ways of assessing? I guess that's two different questions, but what are we looking for?
Yeah, well, signs and symptoms do form part of assessment. So
True.
that, yeah, they're kind of the same question. So in our babies, yes, can breastfeeding, pretty much any breastfeeding problem that you can think of may be related to a tongue tie or at least, oral dysfunction. It doesn't always have to be ties. We can have oral dysfunction without having ties, but they do need to be checked for and screened for. So low milk supply, nipple damaged, not gaining weight, lip blisters, thrush, reflux, that unsettled, colicky. You can't see me, but I'm doing a little inverted commas colic. Do they have colic or do they actually have reflux and feeding problems? And mum's pain, of course, as well. Very painful to feed, in most cases, a baby with a high palate and a tongue tie. So from there, the sleep and breathing difficulties in babies as well can be part of it, because babies can feed in a way that mum doesn't quite realize that it's not working, or the health professionals around her don't realize it's not really working, and then mum adapts and they get over it. So I go through people's history in my appointments, no matter what age they are. And if you just ask the simple question, like, how is breastfeeding? And mum said, oh, yeah, they breastfed for 18 months. It was fine. And then I ask the next question is, oh, okay, so you didn't have any mastitis? You didn't have any pain? And then from asking more questions more deeply, mum might start to say, oh, yeah, for the first 3 or 4 months were awful. And I went to three different lactation consultants, and you started to get a bit more of the story. Whereas, because my point was there that looking at it properly, looking at breastfeeding functionally, as those appropriately trained professionals do, you can uncover dysfunction a lot more than, say, someone who just says the latch is fine and this is something that you have to live with until it gets better. Signs and symptoms from there is, are they a really tense, rigid baby? So what's underneath the tongue, that frenum, part of that is fascia. So when we've got a tight tongue from tongue tie, there can be tensions in the rest of the body as well, all the way to the feet, because that line of fascia goes down the throat into the rib cage, into the pelvis, down to the feet. So tight, overlapping, curled in toes, clenched fists that they never really seem to quite relax from. Even they've had a feed and they don't get that dreamy, relaxed after state happening. They're still clenched, they're still tight, their backs feel really rigid. And then through the age span, we're just sort of looking at what it is that the mouth, what we need from the mouth, what can be impacted by the function of it. So do they gag a lot when they're very slow to take to solids, don't like different textures, have trouble chewing? Is their speech development not the way that, not on track, not how you expected it? They got speech sound errors, or are they not speaking, age appropriate? Are their teeth crowded? Is their jaw small? Those things are not normal. They're incredibly common, but they are not normal. And the sleep and breathing is part of the picture always. It's not as common in children, but sometimes it shows up with pain. That head, neck, and jaw pain can show up earlier on, but that is more common in late teens and adults. Um, Other things we might consider as part of that bigger picture of oral function and having a relationship with tongue tie is oral seeking behaviors. Like kids, you just can't get things out of their mouth. They're really attached to their bottles, really attached to their dummy. They suck their thumb. They mouth things that are inappropriate. They're always looking for sensory input because that's largely what their tongue should be providing for them, but it's not sitting in the roof of the mouth doing that. And things like drooling because their mouth isn't open and they're not managing saliva, difficulty drinking from cups and swallowing properly. It's quite broad.
A lot of symptoms.
Yeah, yeah, it
Yeah.
is really, really big, which is because it's confusing and overwhelming for parents.
Yeah, absolutely. So that's a big part of your assessment is looking at what the symptoms are and what the history of the child's experience and the mom's experience has been.
Yes. Yeah. It's, incredibly rare that you're going to find someone at any stage in life with tongue tie that didn't have early problems. Like no one that I've ever worked with didn't have some kind of problem. How much impact it had on them and mum and the family at the time is variable, but it would have been there.
Mm. And what about there's a lot of expansion work happening with kids
Mm.
nowadays with those palate expanders. Is that something that you recommend parents look into, or would you suggest assessing the tongue tie first and then going to that after, or could you do one and then the other? What's your opinion on that?
Yeah, they're really it's really mixed as to where you go with that. But the like direct kind of answer to that is yes, I love palate expanders. If we've got narrow palates and small mouths, let's jump in and help. Like that's a great idea. I wish that, like I've missed the boat on that as a child myself. I should have had palate expansion myself. But I was very fortunate to not have any adult teeth removed for my orthodontic work, which is kind of it's the more outdated way of looking at things is that we'll take some teeth out to make room rather than making the space big enough for the teeth because people aren't growing too many teeth. Their teeth aren't unusually large. They're just not growing their jaws. So what the palate expander is doing is making that bone at the roof of the mouth or the two bones that fuse together, they're spreading them wider and making them big enough for the teeth. And the effect of that is they're also making the airway size bigger above them in that nose or upper airway. So then that also makes space for the tongue. So you can also have a high palate without having a tongue tie. So other influences can happen there. All those other processes we talked about, like feeding not happening well, and breathing and chewing and all that not happening well. You can have a high palate without having the tongue tie. But when you have that high narrow palate, you've got no space for your tongue to function as it should. So that palate expander makes well, some people use the analogy like the house big enough for the tongue to live in. And if you have a tongue tie, it's still not going to get up to that space. So you'll still need the therapies and the surgery to have the capacity for the tongue to lift up to the roof of the mouth. As to which one you do first is is a little harder. Again, everyone who provides this sort of treatment will probably have their own preferred protocols, but you do need to look at the individual person. Say a child is old enough to have a palate expander, so they're about 6, but they're not capable of cooperating with tongue tie treatment at the moment. Does that mean we're going to leave their palate small and not help their airway and not help their teeth? No, like we're still going to do what we can do. And vice versa, if the family doesn't have, say, the funds available to, because this is all expensive, of course, to pay thousands of dollars to have the palate expanded. Well, does that mean we just leave the tongue alone when they're not speaking properly? Well, no, we've still got to help the child in the way that they have the capacity to, and in the way that is available to them. Um, so it is a tricky situation because we also do have to look at what ability they'll have to use their tongue in a space that's too small. So if you have tongue tie surgery and you're left with this small space, it can be difficult to maintain airway health and control of the tongue in that circumstance. So it is very complex, unfortunately. That's why it's so individual to look at what's happening with that person and what's going to be right for them. As a sort of an example of that, I guess I've had a patient that, like when we in orofacial myology, the guiding principles are airway first. It's airway focused treatment. So, if, say, for example, a child has large tonsils and they're having a lot of sleep disturbance as a result of that, and they've been given the option of ear, nose, and throat surgery to have those tonsils removed, but that same child has a tongue tie, in the circumstance of the patient that I'm sharing, he had both. He had the blocked airway and the tongue tie, and as a result of that tongue tie, he had a speech delay. He was in quite a position of not being able to speak at the age of 5, nearly 6. And in that hierarchy of orofacial myology, we should have done the airway first because it's very important to breathe and sleep. And I agree with that. But ENT wait lists are ridiculous. And that's going to vary everywhere where you are. But we were looking at like 6 months for that child to be able to get an airway surgery. So the question there, if we go by black and white principles, was wait for the airway surgery. But the wait list to see the dentist to have the tongue done was like a couple of weeks. So we did tongue first. So even though that isn't, what you might consider gold standard treatment, it was what was right for that child at that time. So it's a similar kind of thing with the palate expander question, I guess, tongue or palate, both, but the order is more what's right for the individual.
That makes a lot of sense because there are so many factors that come into it, and working with the individual, like things are going to be different depending on their situation. And I guess that
Yeah.
highlights why it's important to work with somebody like yourself or a dentist that is trained in this area so you can have that personal direction.
Yeah, exactly. You don't really want someone where you walk in on your first appointment, you've just met them, and they say, "Yep, there's a tongue tie there. I can cut it for you today or next week or something like that." Like that's too fast. That's not enough other people involved to make sure that it's the right decision.
So, can you tell us about how you work with people and the different resources that you have? Because you have so many incredible resources, including your own podcast.
Yeah. So I don't do orofacial myofunctional therapy programs anymore. It just kind of wasn't fitting with mum life because it is repeated and scheduled appointments, and my child likes to collect viruses. So I was constantly, rescheduling and things like that. It just wasn't really fitting. Whether I come back to it one day is a different question, but for the moment, I work completely online with all my one-to-one services. My patients are all Australian based. I have services for oral health, so working with people who have kind of had that unanswered question as to why their child has crowded teeth. Why do they keep getting holes in their teeth and getting fillings every time they're at the dentist? Kind of working through the picture of what's happening there, the missing part from their dental appointments. And I also do help them look at oral function because that can't really be unpacked from dental health once you realize how closely related they are. I just don't do the therapy, but the thing is that there is a lot to work through. Even before therapy to see why this dysfunction is happening. What can we do at home? What can we change? Who do we need to see? So I do a lot of that still because honestly, the therapy is fantastic. I really like it and really recommend it, but it's not for everyone. It's very taxing, very time consuming on families. It needs to be kind of dedicated time set aside to be able to achieve it, and not everyone's in that space yet. So they're looking more for like tools and resources for things that they can change and do at home. So I do mainly a lot of that on my one-to-one services, and then on my products, I have a guide for talking to your doctor about what's happening with sleep and breathing, because that was a very big part of what I do now and what I was doing in dental practice as well is helping people get referrals to get these things investigated because just kind of sort of parents not having health knowledge and education going to the doctor and saying, I think something's wrong, wasn't getting them anywhere. So that guide is to explain what the signs and symptoms are, what it looks like, how to gather that information, and how to have those conversations with your doctor to get you to the next step. It's an unfair burden on parents, but it's kind of just the system we're working on. You have to come in with like a whole project laid out as to what it is going on and what you need. And I have an oral ties masterclass for babies as well, for parents that want to gather all that information about what's happening with babies and ties. And I have like 4 free downloads, anything to do with teeth and mouths,
Yeah, you're
and a
like a
podcast.
dental detective for parents, aren't you?
And that is a lot of what, how people describe orofacial myology. It's like we're doing detective work. The problem that's turning up is the crowded teeth or the mouth breathing, but we're looking at why.
Yeah, and what to do about it because it can be overwhelming, right? Taking care of our kids and when they have health issues or developmental issues that we're not experts in,
Mhm.
it's a lot to learn it all. So working with somebody
Yeah.
like yourself would just it would reduce that overwhelm.
Mm. Yeah, and that's a lot of what it's a big data collection, a lot of information. My health forms parents are often like, why are you asking that? And I guarantee you it's related. We're kind of just like putting it all together and then picking apart okay, so what does this mean and what are we going to do about it? And it is such a relief for parents to have someone do that mental work because, exactly as you said, we're all busy. We've like often have more than one child in the family, more than one health complication. We're working, we're running houses, we've got our own health that's going on. It's a lot. So to go to someone who just does that part for you and gives you the plan, I find it gives people a lot of relief.
Yeah, yeah, that's so needed. And what was the name of your podcast? Is that The Face Place?
Yes. Keep it simple. The
Yeah.
Face Place
Yeah.
podcast. Yes.
So it's a great resource. I've listened to a number of episodes on it, so that's a
Oh,
really good starting point for
thank you.
parents as well. Was there anything that you wanted to talk about here or you think would be important for parents to know that we didn't discuss?
Yeah, there's probably 2 points that I like to bring up for parents whenever I talk about these things. And the first is that, as we've kind of mentioned a couple of times, that this is overwhelming if you're looking at sleep and breathing and tongue ties. And it's not you. Like you are not the one that can't understand it or can't get a grip on it or something like that. It's a very complicated topic, and there are a lot of problems in how health professionals are educated around them. So parents, particularly mums, can end up feeling like they're going a bit insane. They feel like they're doctor shopping or something like that, trying to get answers. So if that is you and you are feeling that way, you're not crazy. So I really like people to hear that message. And the other one that I find really important for people to know about, especially in this area of healthcare, is that common is not the same thing as normal. It's, as I was saying earlier, very, very common for us to have crowded teeth. It's very common for children to snore and have awful sleep. And it's common for kids to have tooth decay, but it's not normal. And a lot of people who work in these areas of health, like with the high pellets, can develop almost a complacency because it's what they see every day and it starts to feel normal. But it's not. We have a lot of work to do with this area of human health.
Yeah, those are such important points. And I think that's the case with our airway health, but it's the case with so many aspects of our health. It can be daunting and overwhelming, and you can feel like you're in it alone as a parent trying to navigate it. And also, there's so many struggles that our kids are going through that seem so common, but they're not. They're not the norm. Well, they're the
Mm.
norm, but they're not normal, right?
Yeah, yes, exactly.
They're not meant to be that way. Well, thank you so much for coming on here and deep diving on tongue ties and airway health. I know that this is a topic that a lot of mothers are curious about and wanting to find out more. So thank you so much for your time.
Thanks for having me.